Dr. Anthony Fauci joining us, director of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. And let's get right into what we were talking about before we started our video here today. The WHO, the United States, joining back up with the WHO. Your thoughts on that and what you've been doing to help with that?
Yeah, well, Mike, thanks for that. This is really an important event that occurred yesterday, actually in the middle of the night, not last night, but the night before, where the WHO had their executive board meeting. And President Biden and Vice President Harris made as one of the top issues on their agenda was to get back to some sort of normalization with WHO. So I was asked, and I felt very privileged to be the person who was asked, was to become the head of the delegation of the United States to the WHO Executive Board and to make some very important announcements that the rest of the world was really waiting for. A, we're going to rejoin the WHO because when you have a pandemic, that's a global pandemic, which by definition, that's what a pandemic is. You have to have a global response. So it was really untenable that we would not be intimately connected with the WHO. Second, we promised that we would pay what, our dues, as it were, because financial support was withdrawn in the Trump administration. We got that back. Then we agreed that we would join what's called COVAX, which is a general consortium of countries who are going to try, and I know will succeed, in getting enough support to get vaccines to the developing countries who can't afford to do that, and also to revoke the Mexico City policy, which was one that had to do with Planned Parenthood in situations where any groups that had anything at all to do with abortion could not get any funding from the United States. So the world was waiting for that, and it was really quite an important moment where we made that announcement. So that's where we are. We're back on the international scene, Mike, whereas before we had withdrawn.
Now, is it an immediate thing or does it take some time to get the wheels going again?
Well, it's essentially immediate in the sense, obviously you're going to have to get the wheels going, as you alluded to, but functionally we're just, back and forth communicating. The money situation will be settled soon. The president is going to address the Mexico City policy he promised literally within a couple of days.
We're talking about the worldwide picture here, and we see these variants cropping up all over the world, obviously concern for the U.S. and concern for all of those watching the situation. Talk about some of those variants and any concerns we're having here in the U.S. seeing what's happening abroad.
Well, Mike, we always take mutations that might have some functional significance seriously. One thing we've got to realize in the big picture, that RNA viruses, of which SARS-CoV-2 is, have a tendency to mutate. Most of the mutations don't have any significance functionally for the virus. So even though it's a mutated virus, it's not really different. There now have been identified, predominantly in the UK, in which a certain mutant or variant, however you want to call it, people call it different things, is now really the dominant isolate in the UK, and that's associated with an increased efficiency of transmissibility. Doesn't appear to have an inherent increase in virulence, but you have to be careful because if you have an increase in transmissibility, you're going to get more people going to go to the hospital and ultimately more people are going to die. So you take that very seriously. The one thing that they're looking at, and we are now intensively looking at that, is what impact is the variant going to have on the efficiency or the effectiveness of the monoclonal antibodies that are used, as well as the vaccine that we've been vaccinating our own people with. Now, we know that variant is in the United States. It's not dominant yet, but it's here. And it's in over 20 states. Looking at it, it does not appear to have a significant impact on the efficacy of the vaccine, even though it might lessen it somewhat. It doesn't take it to below a dangerous zone. The thing that's more concerning, Mike, is what's going on in South Africa and Brazil, but particularly South Africa, because the constellation of mutations that has occurred in South Africa and seems to dominate the strains in South Africa is more troublesome in that it really knocks out the effect of certain of the monoclonal antibodies, but it also diminishes significantly the efficacy of the vaccines. Not enough to make them off the chart where you don't use them anymore, but enough to make us say, you really got to keep your eye out on it. So what's the solution? What are we doing? We're following it very carefully. It does not seem to impact what we're doing here in this country. We've got to be prepared that if we do have a significant introduction and replacement of the viruses that are circulating with these mutants, that we're able to respond by being able to modify if necessary. We don't have to do it now, but modify if necessary the vaccine. The lesson in all of this, people might get confused, is that if anything, this is a really good reason to step up and get as many people vaccinated with the vaccines that we have now. Because when you prevent a virus from easily mutating and replicating, then you prevent it from mutating. So if you don't want to see a virus take over in this country, then suppress all the virus that's here. So we're looking at it carefully. Doesn't appear to have a significant impact on what we're doing, but we want to be ready to be nimble and make changes if we have to.
So right now, nothing along the lines of any travel restrictions or anything like that when looking at the situation.
Well, we're seriously considering on the broader range of what we're going to do about requirements of any types of restrictions from any countries, including South Africa and Brazil. Nothing final, nothing definitive has been decided on that, but that certainly is being considered.
All right. Well, let's talk about the vaccine a bit that's been going out. And some people have their first shot waiting on the second. My question to you, with what you know about the vaccine, are you getting ample protection with one as you're waiting for the second, or does that second one really need to happen for you to be, fully protected?
Well, that's a very good question. And what we know from experience with this and other viruses and other vaccines is that at the end of the primary, you get some degree, not optimal protection before you get the second dose. We don't know what the durability of the protection is, like what happened if you didn't get the second dose. We do know that in the two vaccines, the mRNA vaccines, that you need two doses. The doses should be 21 days apart from the Pfizer candidate and 28 days between the first and the second dose with the Moderna. Now, the CDC has recently said, if you're stretched and you don't have a lot of vaccine around, can it be delayed for another couple of weeks? The answer is optimally, you not want to do that. You want to get somebody to get the second dose on time. But if you have to delay it a week or two, better to delay it than not give the dose at all. So right now, protection after one dose is not optimal, but there is some, to be sure, but we don't know the durability, which is the reason why the clinical trial, where the data guides us, tells us that to be optimally protected with the mRNA vaccines, you need two doses and you're optimally protected after the second dose.
Let's talk about people who are at home. They may be vaccinated. They may be a healthcare worker on the front lines. They have their vaccination, but they're going home to people who aren't vaccinated. So we're going to have a lot more of that. Some people vaccinated, others not. What should the vaccinated people know and consider after they get their vaccine? Should they keep things as they did before the vaccine with their life and what they do?
Well, right now, the one thing we do not know, let's say what we do know. If you're vaccinated and fully vaccinated, you are 94 to 95% protected from clinically apparent disease. That was the primary point of the trials. You are almost 100% protected from serious disease. What we don't know, and hopefully we will get information in the next few months, but what we don't know is you may have been protected from any kind of clinical disease, but you could get infected, be with no symptoms at all, but still have virus in your nasopharynx. So just because you've been vaccinated, if you've been exposed, it is conceivable that you get infected, you don't know it, you don't get sick, you're doing fine, but you're shedding enough virus that you may be a threat to other people. So with that in mind, the prudent thing to do, even though you're vaccinated, would be to wear a mask, particularly if you're around people who have not been vaccinated. So in answer to your question, Mike, it should not change the requirement for wearing a mask.
And when you finally get everybody in the family vaccinated, should your behavior change at all if we're ahead of the point to where we're saying we have that herd immunity, that population?
Yeah, I like the way you posed the question, Mike, because herd immunity in the house is different than herd immunity in the population. And since you're not going to confine yourself completely to the house, very likely, what a better way maybe to pose the question is that when we get in this country, and we're not exactly sure what that number is, but we can surmise, I think, with some degree of accuracy based on extrapolations from what we know about measles vaccination and what's required of herd immunity for measles, that we would likely need about 70 to 85% of the population vaccinated before you get herd immunity. When we get to that point, then you could talk about a relaxation of some of the public health restrictions. Not completely, not everything, but not the stringency which we're requiring now. We're in the middle of a surge outbreak. It'll be different as we get herd immunity in the community.
Let's talk about mass vaccination centers. I've heard a lot of other people talking about the need for these sort of places where they can get thousands of people in a day vaccinated. What are your thoughts on, maybe a more centralized location where lots of people can get vaccinated at once?
Yeah, when you start getting out into the groups, as you know, you probably know, Mike, when the Advisory Committee on Immunization Practices made recommendations to the CDC for prioritization at a time when you don't have enough vaccine for everybody, and you got to have some sort of priority. The first priority in 1A was healthcare providers and people in nursing homes and those who take care of them. Then 1B was people greater than 75 years old and essential workers in the community. And then C, and on and on and on. When you get to the group where you have a lot of people and you really need to do mass vaccination. For example, when you get to people who are 16 to 64 with underlying conditions, you're talking about maybe 80 some odd million people in that group. That's when you really would benefit greatly from community vaccine centers, from pharmacies that can do a lot of people in a very brief period of time. When you're talking about opening up gymnasiums and stadiums and things like that, that's all doable when you get to that group where you really want to do mass vaccination.
With the vaccine rollout, what are your thoughts on it so far? We've seen some people complaining about it being slower than expected, but obviously we have two companies who are trying to mass produce a product in a short amount of time. What is your opinion on how things are going right now?
Well, we need to do better. I mean, obviously, I think we've done well in some areas. I mean, some states, some cities have done really, really well with the initial rollout. Whenever you get the rollout of a very complicated situation, like trying to vaccinate a country of 330 million people in the middle of an outbreak, there will be bumps in the road and there will be hiccups. And that's what we've seen. Like we now, I believe, have something like 16 million people have actually been vaccinated. There were maybe 30 plus million vaccines that were distributed. We'd like to see that gap closed a bit. Now, obviously, there's a reporting delay. So there are very likely significantly more than 16, 17 million people vaccinated. They're just not yet reported to be vaccinated. But what we would like to see is a steady flow of, as the vaccine comes in, it goes into people. You don't have a situation where in some places you have vaccine in the refrigerator or in the freezer and you're not able to vaccinate people. On the other hand, you might have a situation where you have people lined up to get vaccine, but there's not enough vaccine. You want to get rid of both of those extremes. And that's what we're trying to work out to get that better. So we can do better. I mean, you have to admit that. And that's what we're trying to do.
All right. And there's been a lot of discussion about the virus and its impact on Black and Brown communities, impacting them disproportionately. And the Kaiser Family Foundation, just a couple of days ago, looked at some of the vaccination data and found gaps when it comes to the percentage of COVID cases in those communities compared to the percentage of people in those communities that have been vaccinated. Are those things you're seeing on your end that you have concerns about?
It has been a problem before we even started the vaccination campaign, is the health disparity among brown and Black people. First, they have a greater likelihood of getting infected in the first place on the basis of the jobs that many of them hold, which are out in the community interacting with people in essential jobs. Next, when they do get infected, they have a greater incidence and prevalence of the comorbidities that make it more likely that you're going to have a serious outcome if you do get infected. And those are things like hypertension, diabetes, obesity, chronic lung disease, kidney disease, cardiovascular disease. The social determinants of health are such that those people do, purely on a demographic basis, have a higher incidence. It's not racial, it's the things that they have unfortunately experienced through no fault of their own, literally from birth, improper diet, economic situations, lack of access to health care, those kinds of things. So I would hope that if anything comes out of our experience here, we make a commitment to remove, and it will take decades to do that, to remove those social determinants of health so that Black and brown people can actually have an equal access to a healthy life, which they don't have right now.
All right. And finally, we've been talking about the surges. The last time you were with me in December, before vaccines started rolling out, and the worst is yet to come, we were hearing from many people. Where are we now? Are we getting to the other side of that hill that we're hoping to get over? Or are we still potentially have a lot more tough times ahead?
Well, I mean, I think things will likely get a little worse before they get better. One of the things that's a bit encouraging is that we've seen that the number of cases per day, which were outlandish, just a month ago, where you were getting 300 to 400,000 cases a day and 4,000 deaths per day, we're starting to see that's plateauing. Now, there's still going to be hospitalizations, there's still going to be deaths. But once those cases start to plateau, if they consistently plateau, what you should see is then a diminution in cases, followed by a diminution in hospitalizations, followed by a diminution in death. So even though there are tough times ahead, Mike, I think things, if we stay on course, continue to implement public health measures, hopefully will get better and better as we get into February and March.
All right. Well, Dr. Fauci, thanks as always for taking the time to talk to us. We really appreciate it.
My pleasure. Good to be with you, Mike.
Thank you.